all of you for coming out on this late Friday afternoon. You have a good reason to be here, and we are honored and privileged to welcome Dr. Vikram Patel to be our special guest speaker today. I'm Lynn Videcka. I'm the Dean of the Silver School of Social Work, and this is such a special and momentous event for us. We are the Global Network University, and Dr. Vikram Patel is the global leader in mental health care. We are the Silver School of Social Work, and behavioral health care, mental health care are really the work that we do. We prepare the workforce. We are very fortunate to host Dr. Patel today. I want to thank the McSilver Institute for Poverty Policy and Research, Mary McKay, the director, Gary Parker, the deputy director. I want to give a special thank you to Dr. Debra Paget, without whose personal relationship with Dr. Patel and her dedication to mental health services and human rights for the some of the most disadvantaged people in American society really drives her work and is in the spirit and the mission of our school. We're in for a real treat today. Deborah's going to introduce Dr. Patel, but I think it's a beautiful title to his talk, what the developing world can learn from the developed. No, what the developed world can learn from the developing. See how easy it is to get it the wrong way, and how great it's going to be to get it the right way. So, so I'm thrilled to welcome you all here and to introduce Dr. Debra Paget to you.
Thank you, Lynn. Thank you all of you for coming out this evening. This is a very, very special occasion for all of us and for me in particular, but I just want to say that Dr. Patel, when I think of global mental health, I think of two words, Vikram Patel. And Dr. Patel is a professor at the London School of Hygiene and Tropical Medicine. He's co-director of Sangath in Goa, and is soon to be the director of the Center for Mental Health in Delhi, which is part of a National Institute of Mental Health funded program. But I have to say that if you Google Dr. Patel, you will get so many hits you don't quite know where to stop. He's a TED talker, my first TED talk person that I remember. And I also want to say that if Prachi will hold her hand up and Katie Sue, we visited Goa, we visited Dr. Patel, and he was a wonderful host to us last June when we went to Goa, and we're delighted to be able to work with Dr. Patel, hopefully in the future, on some work on homelessness and mental illness in Delhi. So I don't want to take a minute away from his time. I do want to give you something so you'll remember us for your son, a little goodie bag for your son to take back.
Thank you very much.
From all of us, so you'll remember us. So without further ado, Dr. Vikram Patel.
Well, thank you very much for that wonderful warm welcome, Deborah. Thank you very much to Madam Dean, and thank you all for having come up here on a Friday evening. I'm not sure if I was it shows, I think, the enthusiasm of the students of this university. My own recollection of being a student was that Friday evenings would be quite difficult to drag me in to hear a talk about anything, really. Anyway, I am really going to try and make this a fun talk, but also I should say that the topic of this talk was sparked by a rather curious incident. About a month and a half ago, I was invited by CNN to write a piece about something that happened in America, which I'll tell you about in a moment, that really got me thinking about what the purpose of my work and the work that many of others that I work with in developing countries might mean for one of the richest resource countries in the world. But before I do that, I have to first say this. I believe this is de rigueur for all psychiatrists these days. Unfortunately, I have nothing to declare, but I'm always happy to take suggestions from those of you who are more experienced than me. This was the incident that I was asked to write about. I think all of you know it. It was an enormous tragedy. But when I got this request from CNN, my first response really to the lady who asked me was, I said, well, what can I possibly say? I know nothing about. This is not an area of my expertise. Surely you should ask someone in the US about the mental health implications of these terrible incidents. And she said, no, I really, we've been told, that the work that the people in developing countries are doing might have some bearing on the US mental health care system. Now, the immediate next thought I had was, as I'm sure all of you would agree, is that actually the particular incidents had much less to do with mental health than to do with gun control. And that, in fact, by actually making this a mental health issue, you were actually, if anything, missing the main point, but also perhaps more dangerously stigmatizing the stigmatized. And I thought this editorial in the New England Journal of Medicine pretty much captured the way I imagined the best explanation for gun violence. That mental illness was just a very small part of the overall picture. Still, it seemed to me that here was an opportunity. No matter that it was an indirect opportunity and a misplaced one, but it was an opportunity really to shine the spotlight on a subject that is typically always in the shadows, and that even if it had to happen in this not very well designed way of a school shooting, nevertheless we should grasp that opportunity and make the case for access to mental health care. And actually the US, I'm sorry for those of you in the corner who are not going to see this very clearly, but I'm going to try and tell you what the main points are. The US, of course, has a very particularly difficult story to do with access to mental health care. This is a very important paper from a national epidemiological study called the National Comorbidity Survey, which examined the prevalence of mental disorders in this country and asked people who had a mental disorder whether or not they'd received any kind of care, and there was a very systematic way of exploring this. And it turns out that more than half of people in this survey who had a diagnosable mental disorder in the previous 12 months had not received or sought any kind of care of any description. And it kind of struck me as being quite amazing that the country that had the richest mental health resources on the planet. I often use these comparative figures to really draw out the inequity in the distribution of mental health resources. And when I refer to mental health resources, I'm not only referring, of course, to mental health professionals, such as, for example, many of you here, social workers, but I'm also referring to everything else: dollars, beds, buildings. In any respect, 9 out of 10 of all mental health resources are concentrated in populations that account for 1 out of 10 of the global population. And it struck me as a real puzzle, because our usual response when we think about access to healthcare, and certainly mental health care, our usual response to these sorts of findings is that, well, the problem is in supply. We simply don't have enough psychiatrists, psychologists, social workers, and nurses, and therefore the solution lies in generating more psychiatrists, psychologists, and social workers. But I think this particular cartoon really captured in my mind the real problem. The problem, it seemed, really wasn't the number of mental health professionals, but actually the way they actually practiced. It seemed to me the problem wasn't just, of course numbers are important, but up to a point. And it seemed to me that in a richly resourced country, we needed to rethink really the idea of how, where, in what format mental health care was actually being delivered. And I had a hypothesis for this talk. And the hypothesis was that the fundamental reason for one of the main reasons for the very large treatment gaps that you see in richly resourced countries, certainly it is in supply obviously, is all these other factors. The fact is that psychiatry and the related disciplines of mental health care have become increasingly remote from the communities that they serve in many different ways. For example, that the interventions that are being advocated are heavily biomedicalized. They do very little really to mobilize and harness the sorts of individual and community resources that I think everyone with a mental health problem has some access to. They're delivered in incredibly specialized settings, often far removed from where people live. And finally, the language that we have invented. I say invented because we don't really need some of the words we use. We've invented words and labels and language that are completely alienating. And indeed, I would argue sometimes even the source of stigma. Instead, I think in all these respects, some of the very common sense, grounded and earthy approaches that people in developing countries are innovating in mental health care. And they do this not because there's some kind of dramatic political ideology. They do this only because there is no other choice. The only way you can actually do mental health care in most parts of the world is in fact in a bottom-up approach. But in doing so, perhaps there might be lessons that could have some value for people in more richly resourced countries. But let me first start by very briefly telling you a little bit about the situation of mental health care and mental disorders in the global context. And this is really a whirlwind tour of a very large body of evidence about the burden of mental disorders. So first of all, just the sheer numbers and the impact. If one takes the most conservative estimate of the prevalence of mental disorders globally, about 400 to 500 million people on our planet would have one or another form of mental disorder at any given point in time. And here I'm not talking about the worried well, I'm not talking about the mild dysthymia, I'm not talking about those outer reaches of DSM that cause so many people so much concern. I'm talking really about severe or serious mental disorders that seriously impair one's ability to live a full life, and even then, you have a very large number. Now, of that 400 million, my guess is about 90% live in developing countries. Now, some of you are aware of the global burden of disease work led by the Institute of Health Metrics in Seattle. So this group estimates the burden of disease using the metric called the DALY, which is essentially a metric that combines the impact of a health condition on life expectancy, along with its impact on years lived with disability. And if you look at the latest GBD that was published a couple of months ago in The Lancet, we found that 10% of the total burden of disease when measured in DALYs globally is due to mental and substance use disorders. So that's very high by any account. And of all the different mental disorders, depression is right up at the top, one of the leading causes of the global burden of disease, alongside such conditions like ischemic heart disease and childhood infectious disease. So these are very burdensome conditions. Now, it has to be said that in global health, these sort of metrics like DALYs, people's eyes usually glaze over when we use them, in part because people struggle to understand really what it means, how does it actually get estimated, and I have to admit, I struggle as well with the concept of the DALY. Most priority setting in global health continues to be determined by mortality. And in that respect, it has to be admitted that mental illnesses do not kill as often as, say, for example, pneumonia in childhood does. Still, mental illnesses do kill in one very important demographic group, and that is in young people. One of the most startling findings of global research is that today, suicide is the leading, or one of the leading, 3 causes of death in young people in all regions of the world, including in the poorest countries of the world. And in the country that I work in, India, a middle-income country, as we showed in the first national study of the burden of suicide in India last year, suicide now kills twice as many people as HIV/AIDS, is killing as many young women as maternal mortality. And I use these examples of HIV/AIDS and maternal mortality because they are global health priorities. And so therefore, by comparing suicide with something that everyone recognizes is a major issue, you can also indicate how important this particular mental health issue is. Now, apart from the impact that mental disorders have on the years lived, the quality of the life lived, and on premature mortality, there is also the other important issue that mental disorders affect other global health priorities. And one particularly important global health priority is that of infant health. And in that area, infant nutrition is a particularly important health priority. So what do we know about the relationship between mental illness and infant nutrition? Well, we now have evidence that, in fact, from more than a dozen studies that were systematically reviewed a couple of years ago in this article, that depression in mothers is a leading cause of undernutrition and stunting. And these were all studies done in developing countries. There were more than a dozen studies, so this is a fairly substantial evidence base now. 50% more likely, roughly, that a child will be undernourished or stunted if his or her mother was depressed after childbirth. And what the authors did was they looked at the longitudinal studies, which is a great way of unpacking cause and effect in a temporal sense, and they calculated what would be what's called the population attributable ratio, what would be the proportion of the population burden of childhood undernutrition or stunting that could be averted if you removed a particular risk factor, in this case maternal depression, and lo and behold, the proportion was unexpectedly large. Nearly 30% of the total burden of undernutrition could be explained by one mental health determinant, maternal depression. Now, I just want to stress again here that undernutrition is a profoundly important global health priority. It's right at the top of the Millennium Development Goals. Of course, maternal depression isn't, but therefore this sort of evidence indicates that if we are to achieve this particular MDG, we're going to have to address the mental health of mothers. Another very important aspect of the global burden of mental disorders are the social determinants of mental disorders. Now, when I started working in this field more than 15 years ago, many people, I used to work in Zimbabwe, many people there would say, but you know, you're working in one of the poorest countries of the world. Here the main issues are the diseases of poverty. And you've come along talking about mental illness. Surely mental illness is not a disease of poverty. Mental illnesses really were perceived as conditions associated with various things such as westernization, urbanization, affluence, consumerism, and I'm sure many of you have also heard these cliches. So when the World Health Organization's Commission for Social Determinants in Health set about really documenting the evidence on the social determinants of any health problem, they asked me and my group to really carry out the scoping work on mental disorders. And as part of this report, we produced the review on equity and social determinants related to mental disorders. What we found was a compelling evidence base from more than 100 countries around the world where this issue had been systematically studied. That is the issue of the relationship between poverty and social disadvantage with mental disorders. And we found that in every single study there was a strong and potentially bidirectional relationship between poverty and mental disorders. What do I mean? I mean simply that if you were living in conditions of disadvantage, you are more likely to develop a mental illness. And if you had a mental illness, you are more likely to slide in to poverty, creating what I call a vicious cycle of poverty and mental illness. In spite of this very robust evidence, people with mental illness are disadvantaged and discriminated at every level of society, starting at the very top, at the level where governments allocate financial resources to address the needs of people with mental illness. This slide from the World Health Organization's Atlas report shows you in different countries of the world, organized by income, what is the proportion of the national health budget that is allocated to mental health. And what you can see in the poorest countries of the world, less than 1% here is devoted to mental health care. And overall, only about 3% of the global funding, the global allocation of healthcare budgets to mental health is allocated to mental health, which, if you remember earlier, I mentioned 10% of the burden of disease is due to mental disorders, and you can see this enormous inequity. More worryingly, though, is the quality of care and the discrimination that people with mental disorders receive when they're admitted to the so-called institutions or hospitals that were built to care for them. In most parts of the world, these are institutions that were built during the colonial period. This was chronicled, for example, in a cover story in the Time News magazine that really described the absolutely horrific and scandalous conditions of care that people with severe mental disorders experience when they're admitted to hospitals in many, many parts of the world. It isn't surprising then that if this is the kind of care you're going to receive when you're in hospital, that most people with mental disorders simply are kept at home. But the word kept is important here, because in the absence of any alternative community-based healthcare system, many of these individuals have untreated illnesses. And as we know that sadly, in some cases, such untreated illnesses are associated with quite severe disturbances of behavior, which mean that families have to resort to very extreme methods to help control those behaviors. Extreme methods such as, for example, this particular woman's situation. This is an image taken from a home in the Philippines. This is a program that I lead from the London School, which was working with a faith-based organization in the Philippines. What you may not be able to see clearly from the back there is this arm here, which you can see behind that door there. This is the arm of a woman who has been behind that locked door for about 4 years when our health teams actually reached this home. She actually suffers from an illness that we know can be fully treated. It's called schizophrenia. And indeed, once the health program reached this woman, she was let out of that room after 4 years and has remained outside that particular locked room ever since. It's this failure for us to address what is clearly an enormous burden of suffering by any standards from a global health perspective, and more disturbingly, our failure to address the abuse of even the most basic human rights of people with mental disorders that were referred to by Arthur Kleinman, one of the leading thinkers in the field of global mental health, as a failure of humanity. Now, let me tell you now about a more positive story. And the positive story is actually that we do know about things that can be done to change the situation. Until about 5 or 6 years ago, if I was giving a talk, I would have been constrained in this particular regard. What I would have been able to tell you was everything I've just told you. But if I was then asked, what can we actually do in very low resource settings to address the suffering, I would have had to really struggle to give you an answer. Today, that situation has changed dramatically. First of all, we now do know that there is a whole range of specific treatments, drug treatments, psychological treatments, and social interventions, evidence-based, and which can be delivered in routine healthcare settings, even in low-resource countries. The World Health Organization's MHGAP initiative has tried to synthesize this evidence base, and only a couple of years ago released what I think is potentially one of the most valuable toolkits in global mental health, a set of treatment guidelines for the management of 8 groups of mental, neurological, and substance use conditions to be used in routine healthcare settings by non-specialized personnel. Very important toolkit, but still we have the startling figure. In the US, the treatment gap is about 50 to 60%. In rural regions of Africa and Asia, the treatment gap reaches 90% or even more. And if I had to include in that treatment, if I define treatments to include things like social interventions that address social determinants, the honest truth is the treatment gap is probably 100%. Now, there are many different barriers for this treatment gap, and before I turn to that, it was this particular matter which had been at the heart of the Lancet series for global mental health that I led in 2007, which really was a great attempt for us to use one of the world's leading journals, one of the leading mouthpieces for global health, to devote attention to this neglected area of mental health. We documented the evidence base on mental disorders in the global context and ended with a call to action to scale up services for people with mental disorders built on 2 key foundational principles. The principle of cost-effective treatments, such as what MHGAP has documented, and the principle of the respect for the human rights of people with mental illness. Now, as I was mentioning, there are many barriers to achieving this change. I've listed some of those barriers here. They're all, I'm sure, immediately familiar to you. But it seems to me one of the most important barriers of all, and perhaps this is where some of the most exciting innovations are happening in global mental health, is addressing the barrier of the lack of affordable skilled human resources. Now let us remind ourselves really that one of the most, probably the most important technological requirement in mental health care is not a building, it's not an operation theater, it's not a medical device, it's someone like you and me. It's basically a human being who has the requisite competencies to deliver one or more of these evidence-based treatments. And this is the biggest barrier of all. Addressing this barrier what has been at the heart of my work and the work of many of my colleagues over the last decade. Let me give you a quick idea of really how big, how massive this shortage is. India has a population of 1.2 billion people. Now, just for the sake of an example, imagine for a moment that the ratio of the number of psychiatrists, and I only choose psychiatrists as an example of a mental health professional. You could extend this to all other mental health professional groups. If I had to apply the ratio of the proportion of psychiatrists to the population that you see in the US to the population in India, we would expect that roughly there are 150,000 psychiatrists. Would anyone like to guess what the actual number of psychiatrists in India is today?
20.
Sorry? 20. That's really, you're really hitting the scraping the barrel here. No, it's not as bad as that, but it's about 3,000. In fact, there are more psychiatrists of Indian origin in the US than there are in India today. And actually, there are many such examples. Whenever I give this talk, somebody will get up and say, there are more Sri Lankan psychiatrists in Britain than there are in Sri Lanka. There are more Ghanaian nurses in Britain than there are in Ghana, and etc. And you can find countless examples like this. So this is just to give you a sense that a mental health care system that relies on mental health professionals to be the frontline providers of face-to-face care is not going to happen now, tomorrow, or for the foreseeable future. I discovered yesterday, or day before yesterday, when I was speaking to Professor Mama about how many psychiatrists are trained by NYU alone. It turns out that every year NYU produces as many psychiatrists as the whole of India does. So you can begin to imagine that even this gap is not going to get closed in the foreseeable future in production terms. We can ramp up production as much as we possibly can. We still are never ever going to get anywhere near the sorts of human resources that you see in the West. So I have to be inspired by other ideas. And I'm inspired by this woman. When I started work in this field more than a decade ago, the first thing I looked around myself and said, these shortages in human resources for health is not unique to mental health. This is true of every area of health. There are not enough pediatricians in the world. There are not enough anesthesiologists in the world. There are not enough any kind of medical specialists in the world. How have these other areas of global health addressed the human resource shortages they experience? Well, they've addressed it, for example, by using women like this, Anjana, the woman on the right-hand side of this image. Now, as you can see, Anjana doesn't quite look like a pediatrician. She's actually a lady who lives in a village in one of the poorest districts in India. I actually got this image before I, in fact, met her in her home. I only met her for the first time a couple of months ago. As you can see here, she is weighing a newborn baby here. What does Anjana do? Anjana does one of the most incredibly important healthcare tasks ever. She saves newborn lives. She does this by having been trained as a community worker to diagnose and treat newborn pneumonia, the most important cause of death in newborns in the world. Now, clearly she's not a neonatologist. How in heaven's name did this happen? Well, it happened because in this area of central India, there are no neonatologists, there are no pediatric intensive care units, and so when a baby develops pneumonia, which is characterized by very high fever and breathlessness, the baby just dies at home. A group that was working in central India, a pioneering group called Search, led by one of the icons of global health really, Dr. Abhay Bang and his wife Rani Bang, decided that they couldn't just simply watch babies die because there were no doctors. So what they were going to do, we're going to use local women, train them up in how to diagnose and treat newborn pneumonia, and let them loose. But also they realized that when they did this, this could create a lot of anxieties in the medical community, in the professional community, about safety, first of all, and effectiveness, secondly. So beyond just the ideology of training these village women, they also carried out the first randomized control trial, a cluster randomized control trial, in which they randomized villages with women like Anjana with villages that had no other health worker. What they found was an amazingly dramatic 40% reduction in newborn mortality deaths in the villages with women like Anjana. This particular paper is now considered one of the 10 leading, most cited papers in global health, and more importantly, from a public policy point of view, it has now become part of the National Rural Health Mission of India. Today, India has more than 1 million Anjanas roaming the villages of the country, all being trained in this home-based newborn care. That's what the program is called, Saving Newborn Lives Across the Country. And what's even more fascinating in terms of exporting this idea, home-based newborn care is now also being integrated in the national health programs of countries like Malawi and Kenya. So when I looked around me, first of all, I discovered that the mental health care professionals needed to look outside their own walls, and you would discover innovations that are happening in many other areas of global health. It was this kind of work that really inspired me to write my book, Where There Is No Psychiatrist. It was shamelessly copied from the book Where There's No Doctor, written by an American, David Werner, more than 50 years ago in Mexico. And this particular book was really trying to, as it were, take all the clinical skills that I had and try to imagine how these could be delivered by people who did not have the good fortune of having gone through all the education that I had. At that time, however, in 2003, it had to be said there hadn't been a single trial evaluating this sort of community health worker interventions for mental health to date. Still, there was clearly a very strong felt need. Many organizations and now many countries have started using this particular manual as part of their health worker training. The good news, though, from a scientific point of view, from an empirical point of view, is that the evidence base about the safety and effectiveness of these interventions is now finally beginning to appear. Let me take you to 3 examples of randomized controlled trials examining the use of community-based workers for the treatment of depression, the most burdensome of all mental disorders. In the first example from rural Uganda, Paul Bolton and his team from Johns Hopkins and from Columbia University taught ordinary villagers in villages in Uganda to deliver interpersonal therapy, a psychological treatment, and then compared the recovery rates for depression in those villages where you had these workers compared with those villages in which you did not, and found a most dramatic difference. Nearly 95% of people in the intervention villages recovered compared to less than half in the comparison villages. In the second example, Atif Rahman and his colleagues in rural Pakistan, a part of the world which has amongst the highest rates of depression in women, examined how lady health visitors, these are the routine maternal health care workers in Pakistan's national health system, they examined how they could train these health visitors in principles of cognitive behavior therapy and compared the maternal depression recovery rates amongst those mothers who were being visited by these health workers who had been trained with those who were not. And again, found dramatic differences, 75% recovery rates compared to 41%. And finally, in our own trial in India, where we placed lay counselors in primary health centers and really gave them a very low intensity kind of intervention. It was really primary level psychological interventions, form of psychoeducation, but mostly what they did was case management. And they were working across the range of mood and anxiety disorders, including mixed anxiety and depression. And again, when we compared them with the control arm primary healthcare center clusters, again, a very important difference in the recovery rates. Clearly 3 trials from 3 different countries, all using the same kind of human resource, all showing very important gaps and differences in recovery rates from the commonest form of mental disorders. There are now similar examples of task shifting in other more severe mental disorders, such as, for example, this particular trial, again from my group in India, supporting families affected by dementia. And this particular trial supporting people with severe schizophrenia, this particular trial has just been completed. We're writing up the findings. They haven't been yet published, but I can tell you the findings showed that a community-based worker working in the homes of people with chronic severe schizophrenia, providing a range of interventions aimed at improving livelihoods, befriending, medication support, family involvement, and so on and so forth, produced statistically very significant differences between the intervention and control groups in terms of disability outcomes. And I want to really show you a video here which illustrates, it's a clip of the video, and I think the video really says it all. What this particular model of healthcare means, first of all, to the psychiatrists who are involved in the care of people with chronic schizophrenia. Secondly, to the health workers who are actually, as it were, the link between the psychiatrist and the patient, and of course, most important of all, the patients themselves. I won't show you the whole video just because of time, but I'll probably show you about 5 to 6 minutes so you can capture the essence of this intervention.
असे सगळे परिणाम दिसून येतात आणि दुसऱ्या बाजूला असलेले मानसोपचार तज्ञ की जे औषधं देऊ शकतात परंतु बाकीचं सगळं करण्यासाठीचा कालावधी त्यांच्याकडे नसतो इच्छा असली तरी. मग या दोन्हीच्या गरजांची कशी सांधेजोड करता येईल असा जेव्हा विचार आम्ही करत होतो तेव्हा ही पद्धत वापरण्याची कल्पना पुढे आली. त्याच्यामुळे त्या पार्श्वभूमीवरती कॉप्सीची सुरुवात झाली की असं आपण करू शकतो का की मानसोपचार तज्ञ आणि त्यांच्या मार्गदर्शनाखाली हे ले काउन्सिलर्स ज्यांना म्हणतात ते असा त्याची सुरुवात झाली.
कॉप्सी हा प्रकल्प जो आहे तो त्याचा लॉंग फॉर्म असा आहे केअर ऑफ पीपल सिझोफ्रेनिया इन इंडिया. म्हणजे उपचाराव्यतिरिक्त जर काही सामाजिक उपचार पद्धती जर या लोकांना चालू केली तर त्याच्यामध्ये काय आउटपुट निघतील तो अभ्यासनाचा हा ॲक्च्युली त्याचा हेतू.
रुग्ण आणि त्याच्या नातेवाईकांशी खऱ्या अर्थानं भावनिक मानसिक नाळ जोडायची असेल तर त्यासाठी सुद्धा निव्वळ प्रोफेशनल दृष्टिकोन त्या हेल्थ वर्कर्सचा असून चालणार नाही, तर त्याच्यामध्ये एक मानवतेची आणि कळकळीची भावना जास्त गरजेची आहे की जी कदाचित नॉन प्रोफेशनल लोक जेव्हा या प्रोजेक्टमध्ये उत्साहानं सहभागी होतील त्यांचाही त्याच्यामध्ये जेव्हा आत्मसन्मान त्याच्यामध्ये सुखावणार आहे, वाढणार आहे, अशा व्यक्तींना जर आपण या प्रोजेक्टमध्ये सहभागी केलं तर निश्चितपणाने त्याचाही फायदा होईल.
डॉक्टर आणि पेशंटच्या मधला दुवा असा आमचा रोल होता. जे पेशंट घरी गेल्यानंतर मेडिसिन व्यवस्थित घेतो की नाही किंवा त्याचं जे वागणं आहे, जे बोलणं आहे, त्याच्यावर नातेवाईकांनी कशा प्रकारे प्रतिक्रिया देणं गरजेचं आहे, कुठल्या गोष्टी पेशंटनं करणं गरजेचं आहे, कुठल्या नाही करायच्या आहेत, ह्या सगळ्या पद्धतीचं आम्हाला ट्रेनिंग झालेलं होतं.
सर्वात महत्त्वाचं म्हणजे कसं की त्याला मॅक्झिमम त्याचा एक मित्र आहोत किंवा एक कोणतरी वेगळं आहे असं न दाखवता त्याच्याशी बोललं पाहिजे. फक्त तो कुठं चुकत असेल तर त्याला थांबवलं पाहिजे. मग हे बोलत असताना त्यांना घरातले चॅलेंज करत असतात की एवढं वर्ष सोसलं, तर ह्यांना सर्वांना म्हणायचं ठीक आहे आपण करूया, मी आहे तुमच्याबरोबर वर्षभर, हे त्यांना विश्वास द्यायचा. आणि हे विश्वास देत असताना मग ॲटोमॅटिक त्यांचे जे काही प्रॉब्लेम्स आहेत ते हळूहळू ते आपल्याशी शेअर करायला लागतात. आणि ते शेअर करत असताना मग आपल्याला नक्की कळतं की अडचण काही. तसंच तिकडे राहिले होते का?
दोघं पण गेलेले. हो, आमच्या मिसेसकडे राहिलेली.
अरे वा वा वा. पूर्वी नव्हती ना कधी राहिली?
नाही
मिसेसकडे
नाही. पोरग बिरग बरं आहे की चुलते पण गेलेली, सगळीच गेलं घरातली होती आपली तिकडं. सायकल घेऊन दिली पोरग्याला.
सरांनी सांगितलं की अमुक अशी माणसं आम्ही पाठवू का तुमच्याकडं? ते म्हटलं पाठवा की सर, बरोबर आहे, कारण आम्हाला माहिती येते कसं काय गोळ्या द्यायच्या, कसं काय करायचं किंवा काय करायचे, कसं त्याच्याशी वागायचं, कसं काय, हे म्हणलं आम्हाला माहिती पडेल.
हे तुम्ही जे प्रोग्राम हे ठेवलं होतं ना, हां, तर त्याचा पुरेपूर फायदा आम्हाला झाला आहे. म्हणजे औषधांचं तर झालंच, पण औषधांपेक्षा पण ते जास्त म्हणजे संभाषणाने ह्यांच्याशी व्हायचं ना, बोलायचे आणि ते सारखं यायचे आणि प्रत्येक महिन्याला काय इम्प्रूव्हमेंट झालं आहे किंवा अजून काय ह्यातनं म्हणजे अनेक गोष्टी उलगडत गेले ना. आणि परत त्यांचे काय समस्या असतील ते त्यांना सांगायचे. म्हणजे जे आता आपण सगळ्या म्हणजे इथं बोलू शकत नाही तर नितीन दादा त्यांना दुसरीकडं नेऊन ते त्यांचं हां असं एक त्यांना असं एक आपलं मनातलं कुठंतरी मन मोकळं करावं, असं एक मित्र, एक भाऊ, असं त्यांना एक आपलेपणा वाटू लागला यांच्याबद्दल.
तुम्ही मला पहिल्यांदा काय सांगितलं तुम्ही नितीननी म्हणजे CHWनी सामाजिक आरोग्यकर्त्यांनी की तुला असा आवाज येतोय ना, तर त्याचं कारण हे आहे की मेंदूतील रासायनिकच्या प्रक्रिया बदल होत असतात, त्यामुळे तुला तो त्रास होतोय, असं म्हणजे तो एक आजाराचा भाग आहे, तो भास होतोय असं म्हणजे. तर त्याला काही स्किल्स सांगितल्या की बाबा तू दुकानात बसल्यानंतर तुला आवाज येतो ना, तू पेपर वाच, म्हणजे असं वाचनात मग्न हो, वॉकमॅन लावून बस, गाणे ऐक, किंवा मग खूपच आवाजाचा त्रास असेल तर कानात कापसाचे बोळे घाल.
बरेचदा असं होतं की ही कुटुंब जरी मानसोपचार तज्ज्ञांकडे उपचाराला येत होती तरी देखील त्यांच्या अनेक गरजा होत्या की ज्या पूर्ण भागल्या जात नव्हत्या. त्यांच्या घरी कोणीतरी सामाजिक कार्यकर्ता जातोय, त्यांना आपुलकीनं बोलतोय, स्वतःहून फोन करतोय. समाजापासून ही लांब राहिलेली कुटुंब होती. समाजापासून देखील ती पूर्ण आजारामुळे थोडंसं सगळ्याच कुटुंबावरती तरुण मुलगा तुमचा आजारी पडला किंवा मुलगी की जो परिणाम पडतो तो होता. त्यामुळे कोणीतरी येतंय, बोलतंय आपल्याशी, कोणाला तरी आपली आच आहे, याचा एक वेगळा परिणाम त्या कुटुंबियांवरती जाणवतोय असं आम्हाला म्हणजे सुरुवातीला आम्ही जेव्हा हे ट्राय करून टेस्ट करून बघत होतो. त्यामुळे हे करू शकतात ले काउन्सिलर हे, आणि कुटुंबियांना देखील ते हवं आहे.
पेशंटचा आमच्यावर विश्वास ह्या पद्धतीने वाढला की जे नातेवाईक सांगतात त्याच गोष्टी आम्ही सांगायचो त्यांना, पण थोड्याशा वेगळ्या पद्धतीने सांगायचो. आणि बऱ्याचदा असं व्हायचं की नातेवाईक खरोखरच काही पेशंटला, त्यांना पण माहिती नव्हतं नातेवाईकांना की आपल्याला पेशंटबरोबर कशा प्रकारे वागायचं आहे. त्यांना काही एज्युकेशन नाहीच आहे, सायको एज्युकेशन, तर ते त्यांना वाटणार की इतर मुलं अशी वागतात आणि हा का असा करतो किंवा ही का अशी वागते, असं व्हायचं. तर आम्ही ज्या वेळेला मग हळूहळू त्यांना ते प्रॅक्टिकली दाखवत गेलेलो होतो आम्ही की बाबा तुम्ही अशा प्रकारे वागला पेशंटबरोबर तर पेशंटने अशा प्रकारे वागत जाईल.
इतक्या जोरजोरात हसायची की आपल्याला असं वाटायचं चांगलीच आहे ती. मी म्हणायची ही सोंगच करती या, ढोंग करती ती मला त्रास देण्यासाठी. मी मस्त तिला शिवे द्यायचे, भांडायचे तिच्या संग की तू ढोंग करतीयस. मला बाईंनी एकच सांगितलं होतं, तुम्ही तिच्याशी चांगलं राहिला ना की ती व्यवस्थित येईल. रागावलं ना की ती चिडायची आणि ती चिडलेली असली ना म्हणजे आपण गोड बोललो ना की ती लेवलला यायची.
So I think that gives you hopefully a more evocative sort of idea of how this idea of using community health workers goes well beyond just addressing clinical needs. In fact, far more than that. It's much more than medicines. It's at its very basic level, it's about befriending people, but it's a much more profound thing as well. But at this most basic level, actually befriending itself is very profound. Now, I sort of look very much at, you know, I've often get asked, you know, what makes these sorts of interventions work, and I've spent a fair bit of time looking at the ingredients of task sharing interventions, and not just in the field of mental health care, but in fact across all the fields of global health wherever task sharing has been attempted. And I've coined this acronym. I spent a lot of time trying to coin acronyms. And this particular acronym, Sundar, is a especially important one for me because actually it's a Hindi word which means attractive. It seems to me that, of course, you have to be a little inventive. You've got to try and squeeze things in to try and fit acronyms. I don't know how many of you actually spend a lot of time doing that, but I do. But as you can see, I hope you'll agree that I managed to squeeze the 5 important things quite nicely in this one. There are 5 important ingredients that I think work, are central to certainly all of the task sharing interventions that I'm involved with. The first is, I think, the issue of language, and I mentioned this in the start of my talk. I think the language of mental health has become ridiculously complicated. I'm amazed at how complex the words, the jargon, it's almost like we use language as a wall to actually separate ourselves from the communities we serve. And the first thing we do is to strip that off in everything we do. We demolish all these big words. I spend a lot of time with my teams actually extracting words out of the way we communicate by removing everything that has a ridiculous technical meaning, which could be simplified by just using common sense language. So that's the first thing, just simplify the language, simplify the message. Secondly, unpack the treatment, and this is in relation to that. There's a wealth of amazingly good ideas in psychological and social interventions. Yet again, we actually try and almost defend them from the rest of the world by creating more complicated ways of actually what are very, very clever but common sense ideas on how to help people recover and address their mental health problems. So the next important thing is to unpack what, in fact, some great people in this country, people like Chorpita and John Weiss have done, that is to say, dismantle very complex packages of psychological treatments into much more manageable and specific strategies that could be delivered a lot more easily. And in delivery sense, the third important innovation is not necessarily where the mental health professional works, but actually where people live. And typically that means at the very least in the primary healthcare setting, but perhaps most exciting of all, delivering care even in the homes of people with mental health problems, making it less a burden for them in terms of having to come and see you, because of course the honest truth is many mental health problems need continuing care. And even though the care that we think might be free because for whatever reason it's insured or something, there is an opportunity cost that we don't completely count. The opportunity cost of someone having to leave their home and come to the clinic and therefore have to have someone else look after their baby or lose a day at work, etc. So we deliver it where people are rather than where the professionals are. We use whoever is available and affordable in the community. So when you suddenly put on that idea, no one is under-resourced, because one of the greatest resources in all countries is people. And I think that when you rethink or reimagine who can be a healthcare provider and think that anyone potentially with appropriate training and support can be a healthcare provider, then suddenly you go from a situation of lack of resources to a situation of being spoiled for resources. And then finally, and this is extremely important, there is a very critically important role of specialists. I want to really emphasize this in this final part of this acronym of Sundar. Many of my colleagues, and maybe some of you here as well, but certainly within the psychiatric professions and clinical psychology professions, there's a great concern that this sort of work is dismissing the role of more trained specialists. Well, nothing could be further than the truth from that. In fact, all of these task sharing interventions require the active holding and guiding hand of more trained, more specialized personnel. If you remember Anjana's story, let me tell you that the team that leads that program is led by two of the world's most leading medical practitioners. People like Radin Abhay-Bang are not just special, they're completely unique. And I think it's important to remember that their holding hand, their guiding hand is central to supporting and ensuring the safety and effectiveness of these community programs. Another very important thing that specialists bring is a full understanding of the treatment. For you to be able to dismantle a treatment, you've got to actually understand what the treatment actually does. And so it's not about just starting with any kind of combination of strategy. It's starting with knowing how, for example, CBT or IPT works, to be able to then understand which aspects of these treatments can potentially be task shifted. So specialists play a very important role, and of course the next important role is providing support to the community health workers. This is hard work and specialists are there to support them, and support includes finally providing a referral pathway so that no one feels they're going to get lumbered with something that they can't manage, because all task shifting has limits. There is no doubt that there are limits to every community health worker's competencies. We are not training cheap psychiatrists here. We're simply saying there's a whole bunch of things that less trained people can do, so why don't we ensure that they do that? But equally, there are certain things that you do need more specialized personnel, and so it's about reallocating tasks according to the level of complexity to different members of the health workforce. There's another very important concern that some of my colleagues have, which is that we're dumbing things down. We're dumbing down particularly mental health care. I actually don't think this is dumbing down. I don't think it's dumbing down because we're actually running randomized control trials to actually demonstrate whether or not these things are producing clinical recovery. And clearly, if they are, they can't be dumbing things down because they're doing something good for people who are suffering from these problems. Instead, the way I'd rather fashion this is that what they're doing is expanding the range of intervention providers so that you expand access to these evidence-based interventions rather than dumbing them down. And then, of course, finally, I'm sure in a school of social work there must be some politically minded people here. You know, there's obviously the big thought that this could be a subversive argument. You know, we're trying to subvert this monolithic hegemony of medicine. Yes, it's true. To some extent, it is that. But I think beyond that, I think it's really the practical demonstration that health, and certainly mental health, is too important to be left to professionals alone. The next step, as I conclude then, I think it's important that I think the debate in global mental health has gone beyond the burden. The burden is very important. It was an important argument 10 years ago, but I think most people accept that now. 10 years ago, if I was speaking to a global health audience, I probably wouldn't have been invited to a school of social work in New York. 10 years ago, maybe if Debra was there, I would have been invited. But the truth is, let's be honest, you know, 10 or 15 years ago, when you talk global health, who ever thought that mental illness could ever be on that agenda? Today, that has changed. Today, that has definitely changed. Leading agencies, from the World Health Organization through to leading donors like the US government, are recognizing that mental health problems are an important priority in the global context. That argument has been well made. The argument that we know what works is also now being increasingly acknowledged. There is no longer a doubt that there are treatments for many of these conditions. There is now an increasing acknowledgement that even in low-resource settings, we can deliver these treatments using available human resources in a cost-effective manner. The next step, though, is that we need to scale what evidence and knowledge we have up into national healthcare systems, and also to be modest and humble enough to recognize that there is still a long way to go to build the evidence. We have a few trials, that's great, and we should celebrate them, but we need a lot more. There's still many gaps in our knowledge. For example, in the treatment of people with more severe mental disorders, we don't know how task sharing really works there. Although there are a couple of trials, I don't think that's enough. We really don't know how you can share diagnosis. This is a very complex area, and you certainly don't want people getting diagnosed for things they don't have. The task sharing of pharmacotherapy is still something that we're not certain about. So clearly there are still many, many questions that we have that we can test, and clearly more research is needed. Scaling up what we know works, very exciting stuff. Those countries that are moving from low to middle income and therefore having more money to fund health are also funding mental health much more substantially. India, for example, is one such example country. I serve on India's Ministry of Health Mental Health Policy Group. We're writing India's first national mental health policy. But perhaps more excitingly, as part of the 5-year plan for the district mental health program in India, for the first time in India's history, a brand new cadre of mental health worker has now been included and financed. And these are called community counselors or community mental health workers. And their curricula are going to be based very much on the packages of the sorts of programs that I mentioned to you earlier. But in the poorer countries of the world, for example in sub-Saharan Africa, there's still a very severe resource crunch. Unfortunately, these are also the countries that are struggling with a continuing very high burden of infectious diseases and nutritional problems. In these countries, clearly external donor assistance is still very important to drive the mental health agenda. And the good news is the World Health Organization is in fact assisting at least half a dozen countries right now in integrating MHGAP into the national health systems. In terms of strengthening our knowledge base, I think many of you will be familiar with the Grand Challenges in Global Mental Health exercise. This particular exercise was led by the NIMH. And you may all be aware that the first Grand Challenges was led by the Gates Foundation. This is essentially a research priority setting exercise. This is an exercise which seeks to guide research donors where they should park their money. The first Grand Challenges was on maternal, newborn and communicable diseases. The second was on non-communicable disease. And the third has been on global mental health. And as a result of a systematic set of efforts to identify the research priorities, the leading 40 priorities were published in an article in Nature a couple of years ago. But here are the top 5. And as you look at the top 5 list, one thing that clearly emerges is that the top 5 is not about discovery. It's not about discovering the genes that underlie a particular condition or discovering a new kind of molecule for the treatment of a condition. It's actually implementing what we already know works, because clearly there's a science there. We call it implementation science, and it's fascinating that this college of experts that included 30% of whom were neuroscientists, because clearly the Grand Challenge was not about implementation. It was any aspect of all the disciplines concerned with the brain, including neuroscience. And yet it turns out that implementation questions were right at the top of everyone's list, reflecting really the thought that in terms of the immediacy of action, the most likely results on any investment, the highest results on any investment were going to be on backing implementation science. And the Grand Challenges have led to amazing opportunities. This is a back-of-the-envelope calculation that I did, based on all the different grant programs that I know have come in the last 18 months since the paper was published. More than $70 million from a number of different agencies, major donor agencies, including NIMH. And interesting enough, the biggest donor of all is the Government of Canada, which seems to have really espoused global mental health in a very big way and has already committed $40 million in just 1 year to support global mental health. And as a result of this, also a number of new networks that are forming on the back of resources, very fascinating networks, organizations that never worked in mental health but have access to communities in the developing world, suddenly recognizing the importance, and of course part of it is recognizing the resources to now support that work, and all of them are joining this growing army of institutions, many of which are based in the South, promoting the global mental health agenda. There are new training programs. I obviously here I'm peddling the two that I'm involved with. There is a master's course that we now run at the London School. But the course that really is the one that's closest to my heart is the course that we launched more than 5 years ago in Goa. It's a 2-week course taught entirely by people from India. and attracting students from around the world. And it's called Leadership in Mental Health. It's a course that really, at its heart, is about these sorts of ideas on how people can become mental health leaders and promote the human rights of people with mental illness. The great thing about the course, and I say this without modesty really, is that we actually have people with mental illness teaching on the course. And I really do think that direct contact is one of the biggest missing pieces in the training of mental health professionals. They're not just patronizing presences in the room, but they're actually, where I am right now, teaching people about how, in fact, they can be very important players in mental health care. It's really this aspect of involvement of people with mental illness that I want to finish with. To me, that's the biggest opportunity of all. We now have the science, I think, really to tell us what we should do and how we should do it. There is really still a very big missing piece in this whole process, and that is the voices of people with mental illness. I genuinely believe till the voices of people with mental illness aren't actively heard on the global stage, we will always still be seen as a marginal group. We will always be seen as advocating for our own professional interests rather than the interests of the people that we seek to serve. And I think working actively to empower people with mental illness to be more effective advocates for their cause, I think could be one of the most important vehicles for professionals. Certainly some years ago, when many of us formed the movement for global mental health, that was what we had in mind, to form a sort of a virtual platform on which people with mental illness and professionals like ourselves could really stand shoulder to shoulder and argue for our common cause. Since then, a number of new user groups, I call them user groups, that's a misnomer because most of these groups actually are people who have no services to use, but I can't think of a better word for them. There are many of these organizations of people affected by mental illness in developing countries. I had a wonderful experience of working with 5 of them over the last couple of years. It was a great partnership. The idea really was for me to understand really their own experiences, not as research subjects, which is how traditionally I've often worked, but really as people and really their everyday life and how they struggle to actually get their healthcare needs met by systems that were simply unresponsive. But also for me to work with them, for them to appreciate the evidence that I've shared with you, and then to build their capacity. That's why the word empower is important here, to build a capacity for them to mobilize themselves, to organize themselves into effective civil society organizations that could then advocate for the rights of mental illness. I genuinely believe that we should be inspired here again by the HIV/AIDS example. You know, we all remember that there was effective life-saving treatments for people with HIV/AIDS as far back as 1993. And yet, it took another 10 years before those treatments were made available to people across the developing world. What a scandal. And yet, I have to tell you, it wasn't scientists, I think, who made that difference. It certainly wasn't, because the scientists already knew what worked well before that. It was people living with HIV/AIDS. It was their clamorous voice demanding for action, shaming governments and donors for their inaction that finally pushed people into making action. I certainly look forward to the day when people such as Ellen Sachs, who I had the privilege of hearing speak in June last year, a remarkable woman who, apart from being a distinguished academic in this country, has also lived with chronic schizophrenia for most of her life. I heard her speak about her own experiences in the US mental health care system. For those of you who have seen a TED Talk, you'd know it's one of the most passionate talks I've ever heard on mental health. But what was very, very moving is what she said as she completed her talk. And I'll leave you with these words because I think they really are bear testimony to the incredible power of recovery from what I must think is the most devastating health condition to affect anyone. Thank you.
See, we made him come fighting a bad cold, so my apologies. It's so delightful to hear from someone in your position in the global network and the knowledge that you have. So thank you so much for bringing that to us this evening.
Thank you, Debra.
Thank you. We have some time for some questions and a little bit of discussion. I have promised my colleague, Dr. Gary Belkin, who's in the photograph, who has known Vikram from some time, This is an earlier visit. He could have a few minutes to tell us about some of the work he's doing on scaling up. But also, we'd like to hear from you all as well. So I'll give Gary a few minutes, but please ask questions.
Thank you, and I'll be brief because I think discussion is really great. And I want to just thank Vikram again. Debra and I crowbarred part of his time out of his itinerary with the medical school, which is really sponsoring the visit here. And I think we've run him ragged, but we really appreciate that we were able to have an event down in the square and with this group and within Silver as well, which has really been a friend to mental health in general and to global mental health when we had no friends, although we're starting to get friends, which is good. It's very easy to comment on whatever Vikram says because I usually agree with him. I just want to actually encourage him to be even bolder the next time he gives this sort of message to a U.S. audience. I'm on the faculty at NYU at the medical school, but I actually spend most of my time overseeing the New York City Public Hospital System's mental health services. I was just looking at data today, and our public hospital system, 11 hospitals, about 100 clinics, last year had 1 million mental health visits in our mental health services, not even in our primary care system taking care of depression or whatever, but in our specialist mental health services. It's an extraordinary volume. And I would say that that system is going to implode, is going to continue to erode in its effectiveness to close these treatment gaps, is going to become bankrupt, and its specialists are going to become irrelevant to the population burden of disease if we don't do these sorts of things. It isn't just a neat idea or politically correct to start looking abroad for fun ideas about health delivery. It's the survival of our system is going to increasingly depend upon it. And I mean it in two ways. One, which we're going to talk a lot about, is closing treatment gaps. I give talks in other parts of the world, and people say, well, in the U.S. you have, a lot of psychiatrists. We have one for, 30 million people. And I say, yes, we have 50,000 psychiatrists, and a person with major depression in New York City has maybe a 1 in 3 chance of getting evidence-based care for it. So it's not who you got, it's how you use them. And we really need to radically rethink how we use them. And that's starting to happen in the New York City system, and it has to happen in our system. So closing treatment gaps wherever you are, requires these kinds of strategies. There's no other way. There's no other way to solve the problem. And even being more creative. We're training big brothers to, ex-con big brothers to gang members in motivational interviewing, behavioral activation, counseling methods. That's the way you're going to create the points of contact that really matter, linked intelligently up to other levels of care, but intelligently moving them along those levels of care. So closing treatment gaps, we have to think this way. But another thing that got me into the field of global mental health is how do we make mental health systems more relevant to the social impact and social determinants in which mental health issues are embedded. And we're not going to crack that nut if we don't also rethink about the design of care. I got into this whole field, Sub-Saharan Africa, Haiti, where I do work now, and in sort of the next step. How do we scale this stuff up? Whether it's in our 1 million visits in New York or in low-income settings, how do we scale it? How do we make it integrated into systems? I got interested in looking at other parts of the world because I was trying to solve problems here in New York City. Before I moved to the headquarters of the health and hospital system, I was chief of psychiatry at one of its hospitals, at Bellevue Hospital. And I said, here we're sitting in this building, right? And we know, and one of the reasons many of us are passionate about public mental health is because we know that mental disorders are deeply embedded, both in terms of cause and effect, of community violence, of parenting failures, of school failures, of the fact that most of our homeless are schizophrenic, that 1 out of every 4 of our prisoners cycling through Rikers Island have a mental disorder. So mental illness and mental disorders are intimately related to our main urban social problems, ubiquitously engaged, but our expertise and our capacity to act on those links are highly siloed and highly segregated. So we have a ubiquitous problem and a highly segregated approach to them. The only way we're going to break that nut is to really rethink how we act on those social determinant links. And it's going to be through more fluid, dispersed, participatory ways of using knowledge and skills to improve people's lives, and more so, hopefully, even further upstream to prevent a lot of the cascading effects that we see that result in greater disability. So my only comment is to be more outspoken and almost shaming to the fact that with all the resources that we have so utterly failed to think about simple technologies and innovations that can transform the way we take care of our population, and that we're doing this in New York City. I've been beating my head against the wall for several years, but the public hospital system is now talking about, because the financial incentives are requiring it to. 2% of our patients cost 20% of our expenditures, and 3/4 of them have comorbid psychosis, substance abuse, severe mental illness. So that's what's galvanized the interest. But now we're leveraging that to really overhaul that million visit system to look very differently, to deploy community health workers, to right-size the emphasis on highly specialized providers versus mid-level providers and community-based workers. So that is starting to happen, and it's remarkable to me. As remarkable it is to me, Bikram's been in the global space longer than I have, but there's been a sea change in the last 4 or 5 years in what gets talked about globally. There's been about a 6-month sea change in the U.S. and in New York City, and thinking very similarly. So we're lagging behind on the innovative curve, and we need to catch up, and we will. Thanks again, Bikram.
So now we'd like to hear from you. We have the microphone, and we'll pass it around the speaking stick.
This is, I don't know if this is working. Can you hear me?
Can you hear?
Okay. This could go to Dr. Patel. It could also go to Gary. I guess maybe Gary could speak to it more specifically. But on the topic of how the developing world can inform developed systems here, I'm wondering how our already minimally trained and minimally credentialed ICM workers or case managers that are already in the field, how this model can be translated and supporting who we already have out there. Because it seems like there's a lot of training and a lot of support that comes with this model that we still are lacking somewhat in our system. And I understand you're bringing more people in. I'm wondering what else is going on to be informed by this model within our system.
So I work with a colleague that's also worked with Bikram, Helen Berdelli, who works at Columbia University. We developed a curriculum to train community residents in Haiti and the Partners in Health system to be frontline providers of mental health care. We lifted, without changing a word, that curriculum to train health workers in East Harlem. Community members screened and identified as sort of capable with very similar sorts of criteria that we use in Haiti. It's really a reverse technology flow where we're incorporating a lot of the content in terms to implement here. And similarly, I briefly mentioned training up really street violence prevention workers, ex-cons who are working in Central Brooklyn and South Bronx and other neighborhoods in New York City. We actually used standard motivational interviewing curriculum that are used widely, and they take to it. You adapt it a little bit, but they're very psychologically minded. They take to it. The tools are out there. They're on the shelf. There's really no need to write new manuals. It's really reimagining I thought your point about unpackaging is not only elegant, but so scientifically deep. This idea that it's a wonderful challenge. We branded so many psychotherapies and counseling methods and early childhood interventions and parenting skill coaching methods, whenever everybody has to rebrand a name on it. But we have been not very sophisticated about, okay, what are the 5 key active agents in those sorts of skilled interactions that we can distill it to. It's very easy to brand another version of DBT, but it's very hard to distill it out so it can really be dispersed as a skill to as many people as possible. So we've got this stuff. It's really reimagining and being more sophisticated about how to spread it.
No, just I agree with what Gary just said. I just thought one of the examples that you might, everyone here may be familiar with is the idea of behavioral activation. I mean, what is it? Basically, it's the CBD without the C, and you knock the C off, and you actually make a much easier treatment that's as good as the whole thing. And that's the power of dismantling, is to challenge the hegemony of certain. What are we talking about? We're talking about ideas that have become fossilized, and really there's nothing stopping us from challenging. They're great models, but there's nothing stopping us from asking searching questions about, do you really need the whole thing, or can you just take part of it and have the same therapeutic benefit? And if you could, well then that's good, because in fact you can shift that a lot easier than the whole thing. And there are lots of really amazing stuff happening in the US. I mean, I mentioned Chorpita and Weiss. I don't know how many of you are familiar with their work. They work with children's mental health problems. And they're really at the cutting edge of dismantling. They're actually not only dismantling treatments, but they're also dismantling diagnostic boundaries. So they're working on developing modular packages of care for the whole range of childhood behavioral and emotional disorders. So it is happening here. What's interesting is when I talk to my colleagues who are really pioneering this sort of work here. I mean, Gary's one of them here. There's people in Seattle who've been pioneering, the whole case management, collaborative care, people like Unutsar, Wayne Caton and others, and people like John Weiss and Chorpita. The irony is that their models are also struggling to be scaled up. And I think, it's funny, the collaborative care model, which is by far and away the most evidence-based model for any kind of healthcare in the world, so much so that NIMH will no longer accept proposals. This is what Tom Insel's words. They will not want to fund any more evaluations because it's a closed case. The thing works. And yet, it's not used. And if you ask people like Jürgen Unutzat, say there are real problems with political will and maybe other issues, guild issues, etc., that will stop these interventions from going to scale. Maybe people hear an explanation why this evidence doesn't go to scale in the US.
It's been hard. Just for that example, our hospital system is now, and it took years, is now going to invest $30 million to transfer our entire primary care system along the collaborative care model. But that was, I think, what happened is that the dollars aligned differently, and it's really just that simple. That people were realizing that comorbidities and readmissions and a lot of the high cost was tied to comorbid mental disorders, and the reimbursement looks like it's going to change. And you can thank President Obama for that. It's instead of rewarding the healthcare system for everything it does, it's for how healthy people are getting better. It's transformative.
Questions? Millions. I love when I hear the words like subversive. We're in school of social work. These are good words. We like these kind of things.
So I have a question. Oh,
yeah. Let me give you the microphone so you'll be on.
So the idea of health promoters is very widespread and common in Latin America, where I come from. Usually, the health promoter will be, will have some general knowledge about issues that can help people with general issues of health and illness. And I wonder if you see the health promoter with some additional training in mental health issues as a good model, in the sense that it can deal with any kind of issues, or you think that we need to separate mental health from other areas?
Yeah, I think that's a great question. I mean, so first of all, the example of the health promoter from Latin America is very similar to the model of community health workers in India and in Africa. And in fact, the largest community health worker program in the world, which is the Indian ASHA, it's quite interesting actually, since you talk about subversive. The ASHA is again another acronym. It's not mine. It's a National Rural Health Mission one. It means hope. It's a Hindi word that means hope. But it actually also is an acronym for an accredited social health activist. Now think about that, eh? A national health program that actually has a health cadre whose title ends with the word activist. And I think that also speaks to the idea that there needs to be activism on the ground, mobilizing people, for example, to demand accountable health care. So I think it's a politically charged word. So that's very similar to the health promoter. It's actually modeled on the same idea. It's mobilizing people to actually seek care. That's the primary role. And right now we're engaged with the ASHA program to examine the extent to which mental health care tasks can be integrated within their role. I do think there are limits. And the limit is because that person already has a full job. And to suddenly add an additional set of tasks, potentially would mean that something else might have to give. So I think the way to address this is not just to simply add more and more. And of course, the other problem is these are the weakest people in the health system. They're the least paid. And so it's very easy to keep dumping more things on the community worker. I often joke the only thing left for them to deal with now is climate change. Then we'll solve that problem as well. But I am very wary of that, and I would never advocate just adding things. What I would demand is you either increase the number of people. So if there was one health promoter for a community of 1,000, if you now want the health promoter to do non-communicable disease-related work, lifestyle diseases and so on, then you need to increase the number of health promoters so they handle smaller numbers of people but do more with them. I prefer that model than a parallel worker. I say that because my own experience with silos is that it actually perpetuates the separation of issues that are actually deeply interconnected. So I would be less excited about a community mental health worker, though unfortunately that's the way the Indian government program is going, because very often mental health is a silo. But if I had a choice, if I was able to really engineer the system, I would increase the number of workers so they're responsible for fewer people but do a better job of addressing their combined needs rather than separate. You had a question?
Thank you. I wanted to kind of just comment back to what you said about simplifying language. And I think when I sometimes have that discussion with colleagues or with students, people about how pathologizing or stigmatizing the language we use to talk about mental health can be, I can get an argument that, how important, though, being able to diagnose and have the DSM is. And so just your thoughts on how do we help mental health professionals from all disciplines know that we're not saying get rid of DSM-5, but to rethink and simplify the language that we're using so that it is more empowering to
So I think words have a purpose, have a meaning, beyond the dictionary. And clearly, diagnostic labels also have a value. For example, if they allow you to access specific kinds of resources, like in India now, if you have the diagnosis of autism, which means nothing to any family in the country, but if you get the label autism, it allows you to access specific welfare schemes, both financial and educational, because you have a certificate saying your child has a diagnosis of autism. So clearly in that instance, the word autism has a very important gatekeeping role to accessing resources. However, that doesn't mean necessarily you have to thrust that word to the family and the child and say, your child has autism. You could actually use language that the family finds acceptable to say the same thing. So you could use different words to describe the same thing according to who the audience is. Giving you another example, in primary healthcare in India, we never use the word depression. This might be a curious thing because that's the most important mental health condition in primary care. We don't use the word depression because it actually means nothing. When you translate the word depression into an Indian language, it literally translates into sadness. So you're effectively, it's like the equivalent is going to a doctor in this country and saying, now I'm going to teach you about sadness. This is a disease called sadness. And you can imagine the face of the person. They look and say, what are you talking about? Yeah. But you use the word depression here because that word now has a biomedical significance to it. But when you translate it, it loses that significance in any other language. So we instead have local words that reflect what depression means. So for example, we would say, we're going to try and work with you to help those patients who come here with all these medical complaints like headaches, sleep problems, etc., for which you really can't find a cause. These are stress-related complaints. This is a very long-winded way of saying depression, but it's a more meaningful way of saying it. People immediately say, oh yeah, this is so common, you know. If you can help me deal with that lot, it'll make me feel better. So I think words are important, but I think we can use different words to describe the same thing according to the audience that we're actually trying to communicate with. Either was, yeah.
Hi there. I was interested in hearing if you have any tips in terms of how best to recruit community health workers, or what types of incentives you might provide to actually keep them on board. You were saying earlier that they are often dumped on in terms of responsibility, and often underpaid or have very little in terms of what they are paid. So what recommendations do you have to keep them on board, bring them on board?
Sure. Yeah, that's a very lively research area as well, because obviously there are different models. In some places people get an honorarium or a stipend. In other places it's incentivized. So in India we have both these models. So the ASHA model is an incentivized model. So every woman, for example, who's mobilized to have her delivery in an institution, the ASHA worker gets paid for that. So this is an incentive to mobilize women not to have home births, but to have institutional births. In other situations, you get a routine salary. In a third situation, you get a mixed model of financing. I'm not sure I really know which is the best model. I can see the pros and cons of each of those. The incentivized model clearly is an outcomes-based one. But I always argue, if that's the right model, why don't we pay doctors and nurses like that? You know, it seems a little unfortunate that the only people who have to be paid on outcomes-based ways are actually the weakest people in the health system. So I don't have a direct answer which is the best model, but there's certainly obviously these different ones. In terms of the kind of people who make community health workers, there again is a fairly interesting literature on this. If I had to tie it all together, the main thing is they live in that local community. That they speak the language, that they have a social class affiliation with the average person in that community. If you remember that slide I showed about right at the beginning, the cartoon, I think there's something in that cartoon that is also about class. You know, that the psychiatrist or the mental health professional is in a different class in society to the persons they serve. And actually there is a class differential that acts as a barrier. And I think the idea of a community health worker is something that I'm comfortable. You know, maybe you remember the video saying, you know, I'm very comfortable talking to him. You know, he comes to the house, he's a friend, he sits there, he dresses like me, he talks the same language, he eats the same food. And that also is a very key element of an attribute of a community worker.
One more question? Do you want to be the...
There's a lot of pressure.
Oh, I'm sorry. Okay, sure.
Hi. So it's a little bit outside of what we've already talked about, but my question comes from an experience I had in northern India, observing Tibetan refugees getting help through the treatment of basically using religious and spiritual language. And I'm wondering what your thoughts are on encouraging the relationship between spiritual centers and mental health, especially in a world where we're in need of more people to treat mental health.
So sorry, your question is about the role of spiritual healers or spiritual leaders?
Not exactly. So yes, the role, but what your thoughts are on encouraging perhaps a relationship or a more important relationship between spiritual centers that are already existing and the mental health that we are wanting to encourage.
Okay, I understand, yeah. So I think spiritual centers, spiritual avenues are very, very widely used, probably more so than any other kind of avenue for mental health care problems, particularly the mood and anxiety spectrum of mental health care problems. And so clearly by that very simple fact that people are already going to these centers, they have a role to play. And so there is a general sense that working in partnership with a formal system is a good thing. The problem is this. The problem is the epistemology, the actual philosophy is so fundamentally different. So, you know, if I have to apply this to the African context where traditional medicine is the equivalent of these sort of spiritual centers in India, the problem is if you get a group of African doctors and nurses into the same room as traditional healers, before long they will get into an argument. And the argument will be around a basically different understanding of what health problems are caused by. This is almost like a barrier that is existential, because they're just completely different approaches. How do you partner with someone in that context? In fact, they go so far back into history as well, the mistrust, because they're also deeply rooted in religion. Because traditional medicine is rooted in traditional religion, in Africa at least. Whereas biomedicine is rooted in Christianity. It comes with the colonizer. And so the nurses and doctors are all predominantly, mainly Christian. And for them, even thinking of traditional medicine is not just against their scientific rationale, but it's actually against the whole spiritual rationale as well. So there are lots of barriers. You know, I mean, I haven't fully been able to see how one can bridge those. It's a challenge. Maybe the best we can hope for is a mutually respectful, healthy coexistence. More than that might be asking too much.
I want to thank you so much. Thank you all for coming out and giving up your Friday night. This is a very special occasion, and I'm delighted to see you.